Awesome. All right. Well, welcome everyone. Thanks for joining us a little earlier today. We're lunchy time. Um, I'm really thrilled today to have Dr. Marcia Perretto. I think I
You
got
get
it right.
it.
She is a doctor of physical therapy, physiotherapy and wellness specifically. She's has a particular interest in Ehlers-Danlos syndrome, CCI, um, autoimmune disorders, which we're going to hear a little bit about today. And then I actually like to have the speakers kind of introduce themselves a little bit and kind of talk about why you're interested and so passionate about these conditions and treating these patients. And then I'm actually going to just disappear for a bit and I'm going to let you do your presentation. And at the end, we'll have some Q&A and I'll field any questions that come in from the chat box as well. But I wanted to jump right in and give you some time to do your presentation as well. So, Dr. Brett.
Okay. Thank you. Hello, everyone. Thank you for taking the time of the day to be here with me and with Bob Jones. It's a pleasure to be here again and to be invited over and over to share with you what I have learned. I like to say I fail a little less in treating this population than everyone else. I end up becoming, for those that don't know me, getting an interest on the topic or topics involved in around the Ehlers-Danlos syndrome and hypermobility, etc., based on my own personal experience with the trifecta, hypermobile Ehlers-Danlos syndrome, MCAS or MCAS-like biology, and which I prefer to use the language that way just because a lot of us don't present with the specific markers that are looked at for the proper diagnosis. Some of us do, and the POTS. In the process, I came to learn. Um, I also have craniocervical instability and a couple other things. We're not here to talk about me, but through my own experience learning that there was more to it. And then as I start getting more and more patients, I like to say that you guys are my teachers. I learn from each and every one of you a new component, a new need, and I try to address them as personalized as possible. I do believe in the holistic approach. So if it's not only about physical therapy, that's just a small component, very important, yes, but a small component of a whole body, of a whole person. So today, what I want to talk to you guys, and I'm going to share my screen a little bit, but I want to bring to you a little more on the neuroimmunology side of the CCI, AAI, Chiari malformation, and Tethered cord syndrome, and why there is a symptom overlap and why dosing rehabilitation correctly matters more than just putting the diagnosis and setting you free with another label. So without further ado, let me figure out how to share this and hope I don't kick myself out. So bear with me because me and technology have not been very much friends for a long time. So let's try this again. Okay, seems like I
Yes.
got this. Yay. Okay, so now let me try to figure out how to. Do you guys see this in full screen and
Yes,
nicely?
definitely. Yep.
Okie dokie, great. And so let's go ahead. Like I said, neuroimmunology, CCI, AAI, Chiari, Tethered, why this matters, right? So I want to talk about something that I think is extremely important for us, for both patients, clinicians to understand, and why these conditions can really produce such broad, confusing, and even often overlapping symptoms patterns, and why rehabilitation has to be dosed very carefully. So, I also want to disclose very clearly here that this talk is exclusively educational. It's not meant to diagnose or treat any individual person here. And my goal is really just to give you a practical framework for thinking about the overlap between structural diagnoses such as CCI, AEI, Chiari malformation, Tethered cord, and also even make you think about some other diagnoses, right? And while also introducing the concept of neuroimmunology that it's not being very much talked about, but in the way I see it, it's so, so important. The central message of this presentation is really that the symptoms, they are not always explained by structure alone, but they're also not always just nervous system or just inflammation. And in many patients, structural pathology, autonomic dysfunction, and pain amplification and immune reactivity may all be interacting at the same time. And when this is the case, rehabilitation has to be thoughtful, paced, and biologically respectful. I really like to use the word biology a lot, and you guys are going to realize that. So, why this cluster is easily misread? Uh, one of the biggest clinical mistakes I see is that people try to force these patients into only one explanation too early. And yes, sometimes there is one explanation, but this needs to be like really worked through very carefully. The reality is that similar symptoms can arise from different combinations or different factors. A person may have a genuine uh, structural pathology, and they may also have altered mechanisms from connective tissue fragility. They may also have autonomic dysregulation, meaning their body is really not just handling upright posture, circulation, temperature, or stress in a normal way. And on top of that, they may have also neuroimmune amplifications where the nervous system and the immune system are interacting in a way that makes symptoms louder and recovery less predictable. So when a patient says, I have a headache, I have dizziness, I have brain fog, I have tachycardia, visual strain, neck pain, nausea, fatigue, and exercise intolerance, and the list can go on. The symptom list alone does not tell us the mechanism. So the clinical task here is not to collapse everything in one bucket too soon, and it is to ask three main questions. What is the structural drive? What is the what is amplifying the system, and what is safe to load right now? So that's why these patients are often, or patients like us, right, are often misread, and people confuse overlap with sameness. But overlap is not sameness. I like to say that symptoms overlap uh, should widen that differential. Let's put it this way, and not collapse it. Okay, so as you can see on the graph that I put on the right side, at least on my right side, hopefully on yours is seeing the same. We have structure, we have autonomic symptoms, we have neuroimmune, and then we have that part where everything is overlapping. And we shouldn't just assume that everything is collapsing together. So let's talk about neuroimmunology in plain language, right? When I use the term neuroimmunology, I wanted to define this like very simply for you. Neuroimmunology refers to two-way communication between the nervous system and your immune system. And I've been kind of falling in love with this topic so much that I am actually back in school now studying neuroimmunology. I consider myself a chronic student, so that as I start noticing a lot of things happening to us, I started noticing too that this had a huge, so immunology and neurology had this overlap and this communication pathway that needed to be addressed and need to be spoken up. So in plain language, it means that the nociceptive input, the whatever is the causative factor, that mechanical irritation, that autonomic stress, that poor sleep, the repeated flares, and the inflammatory signaling can all talk to each other. So when they do, the entire system can become way more reactive. So let's just talk a little bit. Why does this happen to patients like us? In reality, symptoms will become louder, or tolerance or tolerance will get lower. Um, our level of activity then should be manageable, but and then it's all of a sudden causing all that significant crash. So why? Right? Sensitivity to light, noise, motion, upright posture, exercise, or even manual therapy. Ooh, now all of a sudden that massage is getting involved may become disproportionate. So that thing that shouldn't be a problem is all of a sudden a problem, right? And then because of all this becoming so loud at once, recovery will become slower and less predictable. So that's why sometimes PT might not work well. That's why sometimes whatever treatment you're doing, even that MRI that you had to do, or that DMX, or whatever imaging you did, all of a sudden, major symptoms louder, made you worse instead better, or instead being different because it was just a test, right? So just I want to make sure that you understand that this does not mean that the neuroimmune changes are the sole cause of every symptom. But this is a very important distinction to be made. It means that may magnify the symptoms, intensity, duration, and recovery cost. So let's just think about recovery cost as a key word, an operating word here. So for those that are patients in this lecture, it matters because it helps explain why you may feel much worse than people expect from a scan alone. And for clinicians that are here, and for those that are clinicians and patients as well, it matters because it changes the dosing. So if the system is already reactive, too much rehab, or even if that too much rehab looks reasonable on paper, it can act like another stressor rather than a therapeutic input. So do not use neuroimmunology to deny the structure. I like to use it to explain why structure alone may not fully explain the lived symptom burden, right? So let's look into a little more in depth on that. So let's look at the practical model for CCI, Chiari, and Perretto. This slide will show you more like the working model I like to use clinically when I'm looking at patients like us. So on the left side, we can start with the connective tissue fragility and the abnormal mechanics that can increase the strain, the traction, or compression in different parts of the system, depending on the diagnosis and each patient, right? That ongoing input may then contribute to autonomic instability, protective guarding, altered pain processing, and neuroimmune amplifications. And as that happens, the patients tolerate for daily load, the patient's tolerance for daily load will decrease. So they may become more symptomatic with basic upright things like daily, day-to-day things, visual tasks, exercise driving, seating, tolerance, even conversations or cognitive effort might be too much. I have had a lot of patients come in and say, it's hard for me to carry a conversation for too long. It's draining. And on a sort of regular person, you might feel like, what do you mean it's draining to have a conversation? But it is. Okay. So this model also helps you understand why some people look uh, um, like worse clinically than imaging alone would predict. So it's that person that comes in and like, your tests are okay, or you only got this one little thing, and that's not reflecting all this that you're telling me. And that's sometimes how we get shipped out to psychiatry, right? Well, we should be shipped out to immunology, maybe, right? Or someone that understands neuroimmunology altogether. So that would be the best referral. Um, but I just want to be careful with one thing here. This is a clinical working model. So this is not a claim every patient follows. So uh, not every patient is the same. Not every patient has the exact same pathway. And this is not a claim that one mechanic is explain everything. So let's just keep that in mind. Okay. Uh, the value of this model that I apply is practical. It reminds me, and it's hopefully help you to see it and remind other clinicians and patients alike that a structure may contribute to the initiating signal, while the pain processing, the neuroimmune factors can widen the phenotype of the presentation. So this is why good rehab is not just about strengthening, it's about understanding what the system can tolerate without being pushed into another flare. All right. Um, so let's look now how this look like in the Chiari malformation, right? When we think about Chiari malformation now, we're dealing with a structural issue involving the hindbrain descending, and in some cases, the altered CSF dynamics and the crowding around the foramen magnum, right? So foramen magnum, for those that don't know, I'm pretty sure everyone knows, but let's just pretend there's someone here that has not learned that part yet. Let's be fair with everyone. So the foramen magnum is the hole on the base of the skull where the brain and the spine uh, kind of communicate, or the brain and the structures of the brain connect into the spinal cord. And that's where the Chiari can form, because that hindbrain can just descend a little bit and cause a lot of symptoms. So the reason this becomes a bit confusing clinically is that the symptom language can overlap with many other things as well. So patients may report that occipital pain, the headaches with Valsalva. Valsalva means like bearing weight, right? When you go to the bathroom, when you sneeze, when you cough, that's a form of Valsalva. Dizziness, nausea, visual symptoms, loss of balance, cognitive fog, neck pain, sensory sensitivity, and even exercise intolerance. So some of those symptoms can also show up in dysautonomia, migraines, upper cervical instability, central sensitization, and a general systemic overload. So now if we don't know what we are looking at, or we're only looking for one thing, we're going to just see what we want to see, right? So the point is not that Chiari equals all symptoms, but the point is that Chiari may be one important structure contributor with a much broader symptom presentation. All right. So, from the rehab perspective, now, the takeaway is that you do not treat the symptom list in isolation. You ask whether there is evidence of the hindbrain crowding, or pressure sensitivity, whether motion or pressure changes worsen symptoms, whether the patient is reactive to strain or to Valsalva, and whether rehab inputs are inadvertently increasing intracranial or cervical load. So, in other words, with Chiari, we have to respect that uh, there may be a true structural problem, while also recognizing that the overall symptom burden may be amplified by autonomic and neuroimmune mechanisms. Um, so let's just keep like an open mind that symptoms can be from different reasons. And if there are two reasons that may cause occipital pain or headaches, we need to understand that there's two reasons or three reasons that can cause that could amplify that symptom. So now it's a little harder because you're going to be like, okay, is this headache becoming worse because of this, because of that, or just because all three things or two things are contributing to that? So now let's talk about a little bit when instability changes the exam completely now, right? So let's look at CCI and AAI. Uh, the core of this is not only or simply neck pain, it is the abnormal motion or the insufficient support in the upper cervical region. And this may change how the patient will tolerate that posture, the head position, the visual tasks, the exertion, and the daily activity. So, for example, personal experience for me, when I go to the movie theater, I cannot sit from the middle to the front of the theater, as that prompts me to be in a slight extension of my neck. And that causes symptoms to the point where all of a sudden the loudness of the movie is too much, the visual stimulation, the changing lights is too much. Uh, my neck starts getting tight and I just kind of start getting irritated. But if I sit to the back, the third row to the last or beyond, I'm perfectly fine. And I get to watch the movie, enjoy, and I have no symptoms. So understanding that how that affects your tolerance and how you also have to adapt to be able to get through your day to day. Patients that have CCI, AAI often will present with the suboccipital pain, though, right? Which is the pain right below the skull, like on that line where the skull meets the neck. It also gives you a sense of heaviness or difficulty holding the head up. Not always immediately, but as the day passes, it's just like, oh my God, my neck type of thing. And we will find ourselves finding strategies to hold our heads because it just becomes unbearable depending on the activities we are doing. Excuse me, we are doing. Visual strain is a big one as well. Dizziness. So, by the way, visual strain is like make sure your glasses are good. Make sure you're seeing a neuro-ophthalmologist to make sure that connection of the eye with the brain is doing okay. Maybe you need the prism glasses to actually help your eyes. Maybe you need eye exercises because your muscles are not responding correctly and they need to be worked. We do a lot of eye gaze work with our patients as well. So it's don't assume everything is coming from the cervical spine. Sometimes there are layers that we can clear and make it. If we make it 1% better, it's 1% better. It's one less thing you need to worry about. Dizziness, nausea, autonomic symptoms, fatigue, again, pressure sensitivity or worsening that get worse with the upright position or prolonged head position. This all needs to be cleared out. So I like to say the exam often tells the story. That's why my evaluations are long. That's why there's so much conversation before I put my hands on you, before we create a plan, because everything you guys don't realize how much what you're telling me and telling the therapist in your sessions is actually helping us figure out what we have to do next. You guys are the teachers. We're just interpreting what's coming through, and we are like adapting the care to respond to what is being said. So, communication is always the key. We don't know it all. All right. We are actually all learning together, except that as clinicians, we have the training to identify what you're saying. And remember, sometimes that symptom can mean a lot of different things. And we need to figure out why or where it's coming from and how it's being amplified. So you may see poor endurance on these patients, overuse of accessory musculature, meaning, for example, I see a lot of overuse of neck muscles on patients that have craniocervical instability. and they are unable to fire the transverse abdominal muscle correctly, load the pelvic floor, things like that. Everything is connected, right? So we need to listen. Uh, Also look for positional symptom changes. So is your symptom worse when you turn this way and look up? Things like that. What do we need to change? What do we need to not do it right now, right? What is indicated, contraindicated, and what is a precaution? Visual and vestibular intolerance can be present, and even fear of movement, because you guys have repeatedly been punished by movement. Like we all been. I remember I'm in the boat with you. We get punished by movement sometimes. So, if remember the experiment with the monkeys, they put the bananas up there, but they also put an electric charged device. Every time the monkeys climb the post to grab the bananas, they will get shocked. Eventually, the monkey doesn't want to climb that anymore. And that's pretty much what happens to us. Not calling anyone a monkey, but that was the experiment with monkeys. But we get afraid eventually to move, and that lack of movement that we have, that we end up that we end up not doing because now we are afraid, it's going to cause even further problems. So that is huge. Um, what else I want to say here? Yeah, I think this on this part of the CCI AAI, when stability is changing the exam. I also want to say, I want to be precise about one thing. Not all of that proves instability. Please don't understand it that way, okay? But when genuine instability is present, the rehab implications will certainly be major. We're not simply loading the neck harder. That's not how it works. Sometimes we even don't go to the neck whatsoever right away. We're trying to reduce unnecessary mechanic stress, improve the load sharing through the rest of the body, improve the trunk support, improve the breathing, improve the mechanics of breathing altogether, improve gaze stability when it's necessary, and most times it is necessary. What else? There's one more thing I want to say about it. Oh, and obviously the most important one, that's why we are here today. Uh, dose the exercise in a way that does not keep re-irritating the system. So if exercises are making it worse, why is it making it worse? Right? And how can we manage? That's why many patients cannot be treated right away to the neck. Even thought you're here for the neck, you're the whole person. Okay. So the cervical spine is one of the areas where the wrong rehab can make a patient dramatically worse. Uh, and more is not necessarily better. Faster is not necessarily better. So I am so sorry when you guys come to me and say, it is going to be this long. Yes, we are dealing with healing of multiple body systems. It's not an ankle sprain. Ankle sprains can, not even ankle sprains sometimes heal that fast, but in general, unique injuries heal a little more easily, not on us, right? But when we're dealing with a multisystemic issue in the presence of a connective tissue disorder, it is not going to be that fast. And generic strengthening model also will fail you because it does not respect the biology of the irritability of the issues. So you got to get the biology of irritability of the issues. You got to get all the comorbidities. You got to get all the systems involved, right? And you got to get each patient differently because each person presents themselves differently. So that's the biggest importance in the whole thing here. So now let's talk about tethered core. And I think the main message on this slide is lasting traction, not just low back pain. Okay. And I know there will be leg pain, there will be gait changes, bowel bladder bowel and bladder, pelvic symptoms, things like that. But I want you to think traction because that's really what's happening. Um, this diagnosis is also very misunderstood if we think too narrowly. Okay, so many people hear cataract and think only about low back pain in general, or maybe some pain down the legs. But clinically, we have to think more broadly about the traction patterns to the spine, the lumbosacral and the pelvic symptoms, the lower extremity fatigue, the bladder and bowel issues for those that are already developing that, the positional intolerance, the neural tension, the abdominal gait strategies, and all the cumulative effect of chronic mechanical stress on the nervous system. So there is that too, right? So what matters here is not that every person has the same presentation. What matters here is understanding that it is a traction-based disorder and it can still um, feed into a much larger whole body symptom picture. So all of a sudden, it's not just back pain anymore. It's affecting your entire body, right? So a patient with tethered may also be the condition, may also be autonomic and stable, will certainly be sleep deprived, will be pain sensitized, and may be neuroimmune reactive. So that does not erase the structural problem. So we can't say, oh, so then I don't have tethered, or then if I treat all that, my tethered is gone. No, but it does help explain why the clinical burden can be so high for those with the diagnosis. From the rehab standpoint, this means that we respect the positional readability, we avoid assuming that more stretching is helpful. We pay attention to pelvic and lumbosacral mechanics, and we focus heavily on load tolerance, recovery behavior, and symptoms provocation patterns rather than on textbook exercise progression alone, right? So let's look at this a little bit, right? So, where do the symptoms overlap across the diagnosis? I tried to do my best putting, I mean, this is by far not even close to the amount of symptoms sometimes some of us experience. But let's just, look into these few ones and how it overlaps with the different diagnoses. I just want to show one thing on this slide. The most important thing this slide is here for is to show that overlap does not mean the same mechanism. So across CCI or AAI, Chiari, tethered syndrome, we're not even talking about other diagnoses again. Patients may share headaches, neck pain, dizziness, nausea, visual symptoms, fatigue, exercise intolerance, autonomic complaints, cognitive fog, weakness, sleep disruption, and sensory sensitivity. So if you only listen to the symptom list, everything can start sounding the same. But the same symptom may arise from different mechanics and in different patients. So dizziness may be more upper cervical and visually driven in one patient, more autonomic in another, and more pressure sensitive in someone else. Exercise intolerance may reflect blood pooling in one patient, and dysautonomia may reflect poor load transfer, post-exertional flare biology. Remember, I like the word biology. I'm using it a lot. Or the patient repeatedly being pushed beyond what their system can recover from. So I get a lot of text messages in the clinic to me directly, to my other clinicians saying, well, it's so easy. The exercise is that easy. Can I put resistance? Can I add resistance? Can I do more repetitions? Not always more is better, right? So, no, if we gave you those number of repetitions, there is a reason. We are not only adapting and accommodating your strength, because remember, everyone only think about strength, We're thinking about building resilience in across multi-systems of your body. So even if your muscle might be ready, your nervous system might not be ready for that. So when I tell you guys, please indulge me, I mean it in a very protective way to you guys. So this slide is not here to say that all these diagnoses are identical. It's really just here to remind us that symptom overlap should broaden the differential diagnosis. So history, exam, imaging, and recovery behavior are what helps us separate the likely drivers of those symptoms. And that distinction is important because if we misread the mechanism, we often misdose the treatment, and that's when you might have flares. And mind as well that that flare might not come from the treatment itself. Sometimes it comes from all the run around you had on your day before you got to therapy or before you got to your mat at home or the after therapy home program session run around that you had, right? Kids are back home for those that have children or work overloads or things like that. They all play a role on dosing. So that has to be taught as well. So don't always think that what you did in therapy or what you did in your home program was the cause. And that's actually even true for the day that, even more true for the day that you like, I've been doing this exercise for 3 days now. I was fine. And now the past 2 days I have flare. What happened in the past 2 days? That needs to be looked at. Okay. And how can we change that? Sometimes we can't change that. So what do we have to change? Right? Remember, symptom burden. Um, so that's what I wanted to kind of go over on this slide here. So let's talk about now why hypermobility or how why EDS, HDS can widen the phenotype of this whole situation. So it matters really here because it can do this in several ways in reality. First, the connective tissue fragility may reduce the mechanical reserve we have. And what does that mean? In simple terms, is that the tissue may tolerate load less efficiently, and joints may rely more heavily on muscular control for stability. The second will be the dysautonomia, which is very common in patients with AGDS or hypermobility. Not everyone has again, but certainly much more common in general, which essentially just means circulation, upright tolerance, temperature regulation. I shouldn't say just, that's a lot. When my POTS is flared, that doesn't feel like just. And even our exertional recovery may already be compromised from the start. So now you add that mechanical load from the connective tissue, then you add the dysautonomia on top of it. And then the third one is like patients like us um, may also have that mast cell-like behavior or that inflammatory reactivity, and then the sleep disruption, the gastrointestinal issues, and even the chronic pain amplification will all like contribute together. And that is going to, my favorite word, increase your biological volatility, making you a ticking bomb, more or less, to a flare. Okay. So, what else I want to say here? I really like this slide. So, let's add that CCI AAI part on this a little bit, or even the Chiari type symptoms on top, or the Tethered cord symptoms on top. So, when hypermobile patients like us if we add all these other symptoms from this other diagnosis, uh, we are not only presenting with an isolated orthopedic problem at this point, we're dealing with a system problems, right? It's almost like a motherboard issue. The circuits are all need to be revised. It's not a one orthopedic or one neuro or one problem in general. And this is why the one size fits all rehab kind of usually fails here. It might work for some of us. Don't get me wrong. Okay. I'm not saying it fails 100% of the time, but usually will because the phenotype is so broad and the reserve is lower and the cost of overshooting ends up being so high for us. So, for the clinicians in the room, this means that we have to progress through stability, through tolerance, and through recovery capacity much more intentionally than we would do on the traditional rehab side of things. And that's why it's sometimes demanding for the traditionally trained physical therapist or clinicians in general, because it's hard to see all this. It's not easy on our side. So, trying to put this big puzzle with tiny, teeny pieces. Have you guys ever tried to put a 5,000 piece puzzle together and the puzzle has like tiny, teeny pieces? That's kind of sometimes how it feels. And we need to put the puzzle together because we owe you, uh, uh, um, you know, to help you identify and improve symptoms. So it's a lot of work, and we want to do it right. We don't want to have to keep going back to the drawing board. But unfortunately, for patients like us, going back to the drawing board is something we have to do a lot. So for the patients in the room, it means your body is not weak because you are failing. It might simply be more easily overloaded. So don't take it too hard on yourselves. Don't think harder or faster or heavier is better. Instead, be kind to yourself and allow your body to heal on its pace. It took me beyond 8 years. I'm not saying yours is going to take 8. Maybe someone else might take longer. I don't know. We can't put a number. We just can put one thing in perspective. Listen to your body, bring back the feedback to us or to yourself, put in perspective, and let's be kind to what your body is in need for that moment. And obviously, move forward and trying to identify if there is another diagnosis that has been missed. Let's rule out if it is there, not there. We need to know. Okay, we're almost done. So, how to appropriately dose rehab may influence the neuroimmune load, right? So, I think if you have to remember anything, remember this slide today. Okay. Uh, Rehabilitation does not reverse the hindbrain crowding from the Chiari, does not change frank instability, does not change tether core. I want to be very clear on this. Rehab is not a way to pretend structure does not matter. Okay. What rehab may do, if it is dosed correctly, is to reduce that secondary amplification of symptoms. It may improve the load sharing. So other body parts are now taking that toll or that load from the neck and helping not to overload the area as much. It may improve the breathing mechanics, which might make you overutilize secondary muscles, might help with autonomic pacing, uh, will help you condition with safe limits, will give you more recovery predictability, and will give you more of a protective guarding, like help you to essentially learn to function within your limits. Some of us will need surgery. Some of us are going to be borderline surgery, but able to function with care. Some of us are not candidates to surgery. And honestly, I like to tell everyone not because you have CCI, you're a surgical patient, not because you have tethered, you're a surgical patient, not because you have Chiari, you're a surgical patient. It's the burden of symptoms when we are able to identify this is really coming from that Chiari or that CCI, when those neurological symptoms are very, very loud and clear that that is the cause that needs to be addressed, then that's when a consult for surgery is necessary. I'll rephrase this. I like a consult with neurosurgery to understand what's happening. but not every single one of us should jump into surgery if it's not indicated and there is not enough neurological presentation for that. Even if you're going to go into surgery, if it's not an urgent surgery that is needed, you need to be prepared, a prehab process. Why? Because if you go in too weak, if you go in with that loud system that everything is screaming at the same time, we don't have a way to know which symptoms we're going to clear, which ones we're not going to clear, which are really coming from there, which ones are not. So sometimes some of us will be disappointed post surgery because some of the symptoms never went away, but because they were not coming from there. They're coming from somewhere else. So, so I think the more defensive claims are the fact that fewer repeated flares are going to be are a good goal. Better activity tolerance, even though you're not running a marathon, but you're doing a run to the grocery store and not getting symptomatic, that's a great one. Things happen in phases. My first goal was to be able to go downstairs in my townhouse and go back upstairs without having to do the booty up on the steps because I couldn't really stand up because of my POTS symptoms. That was my first goal. And then from that goal, I moved to being able to go up, down, and out in the atrium of my condo, and then up, down, out on the park of my condo. And then the temperature got hot, and then I started going to the grocery store, able to pick up one or two things and out. So I progressed slowly over the years. I didn't just one day, boom, and I was doing well. Okay. And each year I take a new sport or a new challenge for my body, but that's me because I was a competitive athlete. Doesn't mean you guys have to do that. Not everyone has the same goals, and all goals are have the same level of difficulty for each one of us because difficulty is a perceived thing. It's not really. If I say I'm going to run an Ironman triathlon, um, why would I do that if I find difficult enough to do a basic thing? So let's respect the level of difficulty that you perceive and work towards that one, not trying to say, well, that is way more difficult than what I'm trying to do. If going upstairs is your goal, that is as difficult as someone else trying to run an Ironman triathlon. I hope there are no EDS patients here trying to do that, please. But if you are, please go for it. And I'm your biggest fan if you were able to accomplish. What else? We also, and lower symptom volatility, right? Lower that up and down on a symptom is very important to achieve with rehab. So those are meaningful outcomes, right? Sometimes pain-free is not a meaningful outcome. I mean, it would be meaningful if it happened, but it's not something that we might be able to accomplish sometimes right away. So that's another thing I think you guys need to remember. It took me 6 years to be able to say I was pain-free for most of the time uh, because pain wasn't budging, everything else was improving. And then eventually it started decreasing. And can I explain why? I don't know if I could. There's again multi-systems, so I don't know what did it. Um, but the most defensible claim here is that rehab directly corrects the structural pathology or directly normalizes, diagnoses specific inflammatory biology. So I think that's what we need to think about. So the way I frame this is that rehabs influences the systems indirectly through safer load, better regulation, and more predictable recovery. That may be enough to materially improve quality of life, but we have to stay really scientifically honest about what rehab can do and cannot do. Okay. It comes in parallel with a multi system approach. So, what right rehab usually looks like? Okay. Let's talk about that. When I say right rehab, I don't mean aggressive rehab. I always got a kick, even when I didn't deal with EDS, I would get a prescription from a doctor that would say, Um, aggressive rehab. I'm like, what do you want me to do? Beat up the patient? Because I don't know what aggressive rehab means, right? It just never made sense to me. Um, I mean, for us, biologically, my favorite word, biologically appropriate rehab. So the right rehab usually starts with reducing the threat and the volatility of the systems. That means that choosing positions that the patient can tolerate better, often recumbent or supported positions first. It may mean working on breathing, trunk control, visual tolerance, spacing, gentle movement. There's a lot of things that can be done before we even think about intensity. So the right rehab is not built on the assumption that fatigue means weakness, and that weakness means the solution of always more loading. And patients like us, poor recovery is often a major dosing signal. We did too much. So I'm watching what happens not only during the session, but later the day in the day and the next day, getting that feedback from you guys. How did you do? What did you do? Because that counts. And I also want to emphasize that strengthening is still important, though. Conditioning is still important. Function absolutely matters, but the order of everything matters. So if we challenge the system before it can regulate and recover, we may create another flare and lose the trust type of thing. So the right rehab really looks like staircase progression, right? Not leaps. Position first, then tolerance, then control, then capacity, then endurance. And every step has to earn the next step before. So let me see. We're almost here. I thought I had 13 slides. This seems like, oh, I have 15 slides. So let me rush through here because I got some questions to answer for you guys. I got another 3 slides to go. Let's go to what to avoid on symptomatic CCI, AAI, Chiari, or tethered cord patterns. So this is about flare prevention red flags in highly symptomatic patients. We should be careful with a couple things. For example, excessive range before control, excessive repetition before recovery, or before recovery is established, and provocative visual or vestibular loading too early, breath holding, high strain, high compression, fast progressions, and assumption that soreness means progress. Ha. Uh, let's also be careful with progressive neurological changes. So if you're doing something and it triggered neurological symptoms, no bueno, okay? If your bladder or bowel symptoms got worse, if your gait declined, if you got new objective weakness, if you had a significant escalation of pressure in your head, or some sort of function uh, change that is major, that needs attention. Those are not situations where we simply should push through. Okay, pushing through, there is very specific things that are pushed throughs, and that's not us. For the clinicians in the room, this slide is about humility. Sometimes the most skilled decision is not adding more. It's backing off. It's acknowledging that we have to back off. The ego needs to be checked at the door. Every morning, I make sure I leave mine at home. Stabilizing the system might be the key, and recognizing that the patient is telling you they do not have the reserve for that current plan that day. So sometimes we have to get that plan and back off to a much easier plan. And that is okay because we're acknowledging the body. Okay. Now, for the patients in the room, this slide is important because it gives you permission to respect your body. I want you to understand that. Respect your body's signal. Good rehab should challenge you, but it should not repeatedly destabilize you. And if it is happening repetitively, even though we're adapting things, something is a little something is not right there. We need to investigate further. All right. So quickly around surgery principles, I just want you to see here I just include this because surgery changes the context, but it does not erase the need for careful biological dosing. And before surgery, the goal is often to reduce the flare burden. Remember, I said at all the beginning, preserve what conditioning is still possible, teach pacing, avoid any repeatedly progressive or provoking unstable or high irritable tissues. Early in surgery, after surgery, the priorities will change. So we want to protect the healing tissues, respect restrictions, support breathing, circulation, start reintroducing the low load control slowly. And then later in the progression, we want to build the trunk and limb capacity first, then progress upright to tolerance, functional activities, etc. So there's always surgeon-specific precautions that we need to observe. And if we might have a concern, we need to go back to that surgeon and discuss individual needs for each patient. So I kind of like to look at a framework. I call it the Actify informed dosing framework because I kind of put this together for the clinic. So we look as a progression from the screen state to downshift triggers, to those one variable only, check 24 to 48 hours. How did you progress? How did you flare? And only progressing is stable. So we go to we train the capacity conservatively. If you are okay, if you came in and we didn't find any triggers that day, we're gonna work out of a yellow traffic light system that I kind of put together here for the clinic, reducing one variable now there. So what are we gonna work with that day? Is that exercise, is that manual, is that posture change? What is the progression that day? And then if you're on red, you came in already drained, we are gonna regulate your system because regulation comes first. We need to keep recovery predictable. So what are the key takeaways here, right? Structural pathology and systems amplification often coexist. The neuroimmune and the autonomic reactivity can magnify symptoms without being the sole cause. Rehabilitation is most useful when it respects diagnosis specific and the constraints that it brings and reduces any secondary amplification rather than provoking more symptoms. And progressive objective neurological change, worsening of medical red flags, or loss of function requires physician or surgical reassessment, close communication with clinicians with the specialties as well, right? So for those that don't know what I am, this is me. If you have any, if you want to reach us, this is you can just scan that. You'll get everything you need, take a screenshot, whatever works for you. And I guess now I'll stop sharing and try to see if I get through some questions. Why do I write my lectures to be 30 minutes and then I talk more than my goodness?
It's fine. We got it. So I do want to do some of the questions that came in through the chat because the folks are here. Oh my gosh, something's moving. And they also kind of relate to some of the questions that had come in previously. So I'm going to
You
start
can
with
you can see me, right? I stopped sharing, correct?
yes, yes. You can
Okay, just making sure I'm not like opening
you
up a million gazillion windows here because I got a couple
you
sensitive
have not
materials on my screen.
disappeared.
Okay, thank you.
Um, there were some questions around whether or not you've had positive or negative experiences with injections. So this person in the chat specifically requested information about like cervical injections for CCI. But
Mhm.
previously we had questions about like prolotherapy and platelet-rich plasma, different types of regenerative medicine
Yeah.
interventions. So just curious about your experiences with those and if you could talk a little bit about it.
So I'll talk from the point of view of scientist brain first, and then I'll talk about from the point of view of what we observe. Okay. So prolotherapy and PRP or stem cell for CCI or AAI or in hypermobile patients specifically, there is no high quality. This is the scientist in me. There is no high quality evidence yet showing that any of this reliably stabilize the craniocervical junction in patients with hypermobility. The published literature is mostly case series, retrospective data, and proofs of concept papers for cervical pain or ligament complaints, but there's no robust trials providing durable stabilization in hypermobile patients. So if I have to scientifically speak about it, I will frame this as experimental or low evidence adjuncts, not established standard of care. But there's always a but, and they say when after the but, whatever came before doesn't matter. Uh, I take it with a grain of salt because I have seen patients improving getting injections. The way I see and the way I work with the physicians that do stem cell specifically injections for the upper cervical instability and the general hypermobility of the cervical spine, we're stabilizing the lower cervical first with multiple injections in different ligaments and capsule and things like that. And then we reassess again. So we do DMX for that. We reassess again to see what has changed mechanically because they're doing the injections and the PT. Then we reassess another DMX to see what has changed. And then after that, we might or might not pursue with referral to a PICL. And then if still, and assuming no neurological symptoms have worsened in the process, right? Because that calls for a different approach. If the PICL fails, and then we have addressed, for the most part, what conservatively could be done. And then we move on to further whatever steps will be.
Can you just clarify what PICL means?
Oh, the PICL is so for those that have seen is Dr. Santana Schultz up in Colorado does is the injection that is done through the mouth to get the alar ligament. So the difference will be that when we do posterior ligaments or when we do injections posteriorly, we cannot access the ligament that is in between the atlas and the axis and the skull. So in between the skull and C2, we have a specific ligament fiber directions that need to be addressed. It only can be addressed through the mouth with injection. It cannot be done through the back of the neck.
Thanks. Okay. Um, and then a couple of questions came in about the immunology of it all. So you talk about that high sensitivity state that's due to normal reaction of the immune system, or is it abnormal? And then as a follow-up, do you recommend that patients seek out a neuroimmunologist? There's not too many of them.
No, there's not too many. So here's the thing. Um, it's a neuroimmunology biology type of thing. So there are a couple things that need to be looked at. First thing is inflammation is a good and a bad thing. Good because inflammation helps us clean out the tissue that got damaged, prepare the tissue to be healed, helps with healing. But then when it gets out of control, it's a snowball, and that's the biggest issue. So true neuroinflammation, neuroinflammation means, so if we think about mast cells and about immune cells, they exist in several tissues of the body. When we have multiple systems being irritated, being an issue, we might end up with that tissue being overreactive. Could be a mast cell like biology, like I like to say, not true mast cell. Some of us do have true mast cell syndrome. The best way, number one, is to have an neuroimmunologist or I'm sorry, an immunologist to rule out any possible MCAS-like biology, things like that. Some neurologists are specialized and only study neuroinflammation. They're very few and far apart. But the biggest thing is not really if you are tested and there is no significant markers for inflammation, it is really more a tissue reactivity that needs to be addressed. So my way of seeing and the way we address in the clinic is calming down the systems through neuroregulation, like we always talk about. And I know you guys are tired of hearing this probably, but vagus nerve modulation, breath work, uh, what's going on in your environment, all this plays a role. Excess of release of stress hormones will cause your body to be more reactive, and that reactivity is the one that we need to decrease. So necessarily you might not have the markers for it, but you might have the biology, the presentation as everything is overreactive. I don't know if I explained that, but that's kind of how trying to make it simple in the subject that's very
Extremely.
complicated. Very.
Um, so this question came in ahead, and it was also put into the chat a little bit, just a little bit more pointedly,
Mhm,
kind of talking about imaging.
mhm.
So I'll start with this question because it's very, very pointed. And you're into the evidence-based stuff. So what's the evidence base about the reliability and safety of that DMX imaging? There's some concerns about, radiation maybe, or it not being recognized outside of chiropractic care. So how do you use those images
Yeah.
when they're ordered by anyone, and like how, I guess, is a good question.
I actually ordered the images myself. So let's talk specifically DMX first. The more up-to-date machines, the ones that I actually send my patients to get it done, you get less radiation on that than you would have on a CT scan. It looks like a lot of images that you're doing. It looks like there is a cumulative effect of it, etc. But it's still less, significantly less. And I went to the point of talking to the person that created the equipment, the DMX equipment, is less than a CT scan. Um, why do I like the DMX? Because I get to see the mechanics. So if you had a CT scan, a rotational CT, you're just right here, or you're looking to the other side. If you had a flexion extension MRI or X-ray, you're here, you're here, you're here. What happens in between? What is my transition? How did you get there? I want to see what's happening on each vertebrae and how that vertebrae is sliding. And you might say, well, why does it matter? It matters because I'm able to see how far I can go with the neck movement. Where is the aggressor? Where is the faulty level? Where is the most hypermobile level? And how are we going to address that? So that for me is key. I agree, it's not recognized. um, I think more physical therapists should look into that. I love my moving skeleton. It makes sense to me to see a neck moving in a DMX. I think more PT should look at that. I think I have a lot of handful of specialists, neurosurgeons, neurologists, spine surgeons that are looking at those now, but unfortunately, they are not covered by insurance yet. So yeah, there is that part as well. Um, Different things also. What CT is best for, like bone and some dynamic measurements. Then so each one will give you a different thing, right? It will be best for some of the dynamic measurements. It will give us that rotational overlap of the facets when we are the only way to see rotational instability of C1 on C2 is through rotational CT. The radiation on that is a lot. It will depend a lot based on the scanner and the protocol utilized. If you're doing with and without contrast as well, that exposes you a little more. But yeah, it will also depend on that. And then the MRI, just since we're talking about it, why not to throw the MRI in the mix already? Because there's like, well, my doctor said I don't need an MRI. I only need an X-ray, a flexion extension X-ray. It is a great tool. It will show us the measurements we need, but that's it. Where is my soft tissue? Where are the compressions that I want to see? how is my ligaments, the remaining, we are not made only of bones and bony measurements. We're made of other tissues there. So I want to see my compressions. I want to see, um, what's going on in general on the tissue. That's when the MRI is going to be way more informative. So you want to have an X-ray, flexion extension, great. But eventually I want to see, because if that did not justify your craniocervical instability, what else is happening with the tissues when you flex and extend? So that would be my call.
That's great. You actually touched on the other points of that question, which was about CT with and without contrast and that kind of stuff. And the
So yeah,
MRI as
CT
well.
with and without contrast is different because it's, if we want to see, it's going to be a CTA, right? With we want to see the flow. So when you rotate your neck on that rotational CT, what happens? Is that compressing any of the arteries on the venous phase? Is that compressing the vein? And because some of us don't have symptoms, you might rotate as well, you don't have rotational instability. Okay, what happened? Is anything being compressed as soft tissue? And that's where we get to see when we do with contrast. And then we do arterial and venous phase, so we get to see everything.
Awesome. A question from previously was talking about getting dizzy lying down, asking to lift the chin for strength, getting pressure in the head. Basically, they're asking, does that indicate cervical issues, vascular issues? And actually, one of the questions in the chat kind of brought up the concept of like dysautonomia and what kind of
Mhm.
testing would something like that cause, require?
So let's first look from the it could, if you're moving your neck and you're getting symptoms, there are a couple different things that can cause. It could be inner ear, could be, but it also could reflect a mechanical, it's definitely a mechanical provocation, right? But like I said, vestibular issues, could be a migraine physiology, could be intracranial pressure sensitivity, could be autonomic dysfunction, and less commonly, but not, why not, a vascular problem. So the key point here is that really the symptoms are being non-specific. So it shouldn't be assumed, for example, to prove that the vertebral-basilar system is compromised, or there's CCI. If the symptoms are being reproduced, severe or associated with some red flags like visual loss, drop attacks, changes in our ability to speak, focal weakness, um, or syncope, right, passing out, then it needs to be evaluated by a physician that understands upper cervical, that understands EDS, that understands the dysautonomia component for target testing, right? Because if you don't have the right, if you're only going in with the eyes of one diagnosis, you're gonna miss everything else around it. So it needs to be someone that has a broader view, that can at least, if they don't understand the entire details of, let's say, dysautonomia, let's say it's a neurosurgeon, it's like, listen, this looks like dysautonomia, but I'm going to send you to this guy that understands EDS and dysautonomia, because from my part, I am not seeing anything. But there is a continuity of care with someone that really understands it.
Yeah, that's really important.
Yeah.
There are two more questions that I definitely want to get to, and I know we're getting really close to 2 o'clock, so I just want to do these first.
Oh, go for it.
So there's questions about the best cervical collar.
Mhm.
So originally someone had asked a question about the best collar that provides traction without too much pressure on the jaw, because they've been saying that was bothering them. They just need something to get the pressure off that connection there. And then there was a question in the chat about whether soft or hard collars are recommended for CCI and AAI neck pain specifically.
So there are a couple different things. So let's first talk about CCI, and neck collar being a prescription or not a prescription, right? Let's forget about the pressure points for now. We'll talk about it in a second. So there are a couple ways that we do this. There are a couple neurosurgeons that like to order a cervical, a hard collar, specifically the Aspen collar, for a couple days, up to sometimes 10 days, 2 weeks, to see if your symptoms improve. If your symptoms improve with the collar, When you have the collar on, you take it off, the symptoms return. That's giving us information on the integrity of your ligaments at the upper cervical spine. So that's a one thing. Now, using collars all the time, since we are at the collar, uh, I don't strongly recommend hard collars all the time. If a patient says, but I really need it, and that patient is not a surgical case, then I will say you can put that collar for 15, 20 minutes every hour to unload. But that would also, if you could lie down and get the weight out of the neck, I would prefer that. But let's say you're working now, you can't. You can't lie down on your desk every 20 minutes every hour. So put the brace on, 15, 20 minutes, allow the body to rest and take the brace off. Because if you keep using it, anything the heart immobilizes the neck will take away from your muscles. And it's not like, every other joint we can put a compression sleeve. We can't put a compression sleeve on the neck, or the treatment will be a success, but the patient will be dead. So now there's the soft collars. Soft collars limits you to doing certain, it's a reminder of head position. It's a reminder of how far in the range you should go, but for some of us might not be enough. And now let's transition into like what type of collar. So essentially, let's pull the scientist brain back in. There is no evidence base for best collar for CCI or upper cervical and AGDS patients. And I'm saying this, but remember, I already said that you can use it with certain strategies. It's all about the strategy that you're putting in, that you establish with your therapist or with your doctor. Collars are imperfect because they trade off support with jaw loading, with position, with venous compression, with swallowing discomfort, and even the skin tolerance. Some of us get like some skin burns. So in general, collars should be treated as individual trials for fit and for symptoms response. Like I just said, soft, a little softer, a little soft harder, or an aspen, on and off so it doesn't take away from your muscles. But also if a collar consistently, and that's the other thing where you might have to order 30 different collars until you find your favorite one. Because if a collar consistently puts you in the wrong position, or it's worsening your symptoms, that is a sign that you need to reassess for fit, reassess for indication, not simply just tighten further or use it longer. Something needs to be changed. Okay.
So it's really more of like an accessory to your longer
Yes.
term. Yeah.
It's
Not,
a tool. It's a tool in the toolbox for us to be able to deal with our symptoms, but not a must wear. Because remember, the more you wear, the less muscle you're going to have to then hold your neck when you are not wearing it. And that is only going to be counterproductive on the great scheme of things.
yeah, exactly. That's really helpful, actually. And then there was a question here about another practitioner. So they have a Pilates rehab practice, and they're working with a patient with craniocervical issues. They want to know specifically what movements to avoid and which should be more beneficial necessarily. And then I also had a question, just more like manual kind of stuff. What's the difference between high and low velocity techniques, and like who are each used on? That's more like
Okay.
technical.
You mean for
Sorry.
manipulation? So let's
Yeah,
answer
yeah,
that one
yeah,
because it's a shorter one to answer. High velocity, low amplitude joint manipulations are the crack. Okay. That will be your crack of the neck. If you do something quick, like when you go to the chiropractor and they crack your neck, they crack your back, that's a high velocity, low amplitude joint manipulation. We have joint mobilizations. which is done by physical therapists as well. So there are PTs training high velocity manips. I was. Um, but there is a graded, like right high velocity or low amplitude are um, grade 5 manipulations, like they're from 1 to 4. They're not going to be high velocity. They're going to be oscillations. So we're going to go like a little more superficial on the tissue, a little slower, a little deeper on the tissue, a little faster down that range. They're different manips, but we don't go for the crack. Okay, that's the difference in between the manips. Did you get it?
Yes. And
Okay,
then the
cool.
question about the
The
Pilates
Pilates,
scale.
yes. So if you're dealing with a CCI patient, so let's just remember one thing. Not every CCI is surgical. I like to draw a line where we call it cervical, upper cervical hypermobility in 50 Shades of Gray, right? And then there's that line that if you cross, you have a craniocervical instability. Medically, when you talk instability, you're saying that something has lost its control and needs to be stabilized surgically. So I like to call it hypermobility in different 50 shades of it. Okay. Um, so that being said, if your patient is not surgical, is not presenting neurological symptoms or mild neurological presentations that the surgeon feels comfortable, that is not a surgical case yet. This is how I would approach it. First of all, avoid anything at end range. There is no reason to go into symptomatic range of motion. Like I can't remember I said about the movie theater. I just don't sit on that row. I sit on the rows that I can tolerate. When I do my Pilates, I know I have things that I have to be mindful. When I do my bridging, I make sure my support is on the shoulder blades. I'm not rolling on the back of my neck. Does that neck need support? Is that support causing overcompensation of the anterior neck muscles, or that is actually taking away and helping? So that's another thing to think about. So any sustained neck loading is not a good thing. So let's not, just because it's a neck problem, adapt a band on the neck and have the patient do everything they need to do. Don't even touch the neck. There's just so much to be done below the neck before we even talk about neck. Any inversion poses, any high strain valsalva. So make sure your client is breathing, because the strategy we hypermobile people have is hold the breath to make things stronger. Transitions matter. It's the same thing with yoga. Transitions are the most important part of yoga. When you're going from one pose to the next, it's not just the pose, it's how you're getting to the next one. Pilates is the same thing. When you're transitioning from point A to point B, how is that transition happening? Joseph Pilates was very picky on how to get on and off his equipment. Let's remember that. That's why group Pilates sometimes is not a good thing. Because if we are not mindful of what our needs are, it's not a bad thing either. But if we are not mindful of what our bodies need to do during the transitions, we might get in trouble. Um, and anything like if you have craniocervical instability, sometimes overhead arm work is not a good thing because the neck is everywhere. There is no stability. So shorter lever of motion, uh, instead arms straight, arm elbows bend. You know, you can do this or you can do this. Same muscles in essence. Close chaining the exercise. Close chain. Put a ring, put a ball, put a band, put things that the extremities are in contact with something, so it gives us an idea of where we are in space, because we don't know where we are. Our bodies are not helping on that. What else? What tends to help a lot is then supported positioning, including the head always supported, because then we don't overload the neck. Trunk and scapular control comes first. Breath coordination with movement is key, even if you have to slow down the exercise, because being assertive on the movement is more important than doing too many repetitions with an improper posture or position. Um, Visual and vestibular pacing, using some low load isometric, stopping within certain parts of the range of motion, and then the gradual whole body load sharing type of concept where the rest of the body is taking more of the effort that should be directed, normally we direct to the neck. So what else do I want to say on that? Uh, yeah, let's not strengthen the neck harder, I should say. Control comes before challenge, but that's no secret for Pilates instructors because Joseph Pilates called it the art of contrology for a reason. So we need to go back to the roots, to the basics. And recovery comes before progression. So if your client took more than an overnight and maybe slightly sore next day, uh, took longer than that to get better, to feel better, we did too much with them. So we have to rethink the intensity because sometimes educating, working on form, working on breath is more important than pounding a million exercises.
Yeah. To follow up on that, and then I feel bad. I know you were working on some of the questions already, so maybe we can send out some responses too if we don't do this again soon.
Yeah.
But
Yeah, I
just
actually wrote
yeah,
up a lot of stuff for you guys. So if
perfect.
you have more questions, I can always add them to the email for you.
Perfect. Thank you.
Mhm.
But just to follow up on what you just said, because this had come up previously, how does the patient, so you're talking about the provider, how does the patient then distinguish between good and bad muscle soreness after the fact? And I know you talked about a little bit like, well, what else happened that day or the day before?
Mhm.
How can the patient help the provider better treat them?
So the first thing we need to think is that um, the concept of no pain, no gain should be out of the window um, because we can't identify whether we are having muscle aches from the work versus joint pain from overtraining the joint itself. So that is out of the window. Then we also need to identify. So there are a couple of things. Okay. How do you know if it's a good muscle soreness? You're just like, it's that thing that you press your muscle and say, oh, that it's kind of almost like a good pain. It's like, you know what? I woke up feeling okay, maybe a tad tired, but that's my baseline. My muscle feels like, oh, when I do that banding out there, oh yeah, my biceps got the workout yesterday, but it's not joint pain, it's not shoulder pain, elbow pain, things like that. Then you also know that you woke up in the morning, you're not completely wiped. You're not like, oh my God, what did I do? It's a metabolic tiredness. It's like I slept 8 hours and I feel like I was up all night. Or you even slept, you went to bed, you didn't wake up. That happens to me sometimes when I overtrain. Do what I say, don't do what I do. Okay. Uh, I toss and roll all night long, but I don't wake up. So I wake up hurting all over. Even my blanket felt like it was a weightlifting session overnight because I couldn't rest because I just drained myself so much. So I woke up more tired than I went to bed. I woke up more fatigued than I went to bed. My GI might not be okay. And that's in general for everyone. Your GI might not be okay. You might be a little more nauseous. You might have a little low grade headache. Sounds, lights can be annoying. All this is your body telling you, hello, you did too much yesterday. Now, your body cannot tell you if too much was the session, the PT session, the exercise, the Pilates session, the exercise, whatever, or if it was like running after the kids, dealing with work, that phone call, that bad news that came across, the stress in dealing with something, that all adds on. So now you're going to have to sit back and say, okay, have I done the session before? Yes. Have I had these results or this type of flare? No. What else have I done yesterday then? And then say, if you're coming to a trainer, to your therapist, to your Pilates instructor, you're going to say, listen, last time I had this flare, but then 2 days later after recovery, I did the program again and I was fine. But I want to give you heads up. And what should I do? And that's when we have our here at the clinic, but it needs like a little adaptation or a little understanding on how to use it. But we have like that traffic light system where if it's a good day, it's green to go, but not overdue. If it's yellow, what am I taking away from my plate today because I already don't feel that great? And if it's red, maybe it's time to cancel all those extra activities. And if you're going to therapy, if you're going to Pilates, it's time to work in regulating your system with breath work, with vagus nerve modulation, humming, meditation. This is how it goes.
Awesome. Thank you, Dr. Perretto. I just put your contact back in the chat a little bit, but we'll share that
Thank
again.
you.
And
Uh-huh.
I just wanted to thank you for doing this again. And
It's
I
my
think we're going
pleasure.
to plan on doing it again soon, but we'll plan
Yes,
something.
we have to figure out what dates, and my goal is kind of to build on each lecture so it kind of makes sense instead of just repeating
Sure.
over and over the same things, kind of build up so it makes sense for whoever is watching the series.
Awesome.
Um,
That's
okay.
perfect. Thank you so much.
Okay.
And thanks everyone
You're
for
welcome.
joining us. And we'll talk again soon.
Thank you, everyone. Nice to have you all.
Thanks.
Bye.
Bye.